Good afternoon and welcome everybody. I'm Chad Shear, Senior Vice President for Policy and Program at United Hospital Fund, and it's my pleasure to welcome you to today's webinar on adolescent behavioral health. Just quickly, for those of you that may be new to UHF, we're a 145-year-old nonprofit dedicated to building an effective and equitable healthcare system for every New Yorker. We achieve this mission through a broad mix of research and analysis, convening, and on-the-ground programs, all focused on dismantling the operational and policy barriers that prevent equitable opportunities for health. One small part of that work over the past 5 years has been a collaboration with Boston Consulting Group on a series of reports that present unique compilations of publicly available data alongside evidence-based estimates of the longer-term health and societal ripple effects of those issues. As we thought about topics for the latest ripple effect report you'll hear more about in just a minute, adolescent behavioral health was and continues to this day to be in the news on almost a daily basis. And rightfully, it's being reported as an outsized and growing problem. It is important, though, to understand that this is not a new problem. While the pandemic did exacerbate some of these issues, the worsening trends existed well before March of 2020. So for today's program, we're going to do a brief presentation on our latest ripple effect report on the adolescent behavioral health crisis. And then we'll engage in a panel discussion with leaders from 2 organizations who are valiantly responding to the growing adolescent behavioral health challenges in unique and different settings. There will be some time at the end of the webinar for Q&A from the audience, so please use the Q&A feature at the bottom of your Zoom window to submit questions. With that intro out of the way, it's my pleasure to introduce 2 members of the staff here at UHF that were instrumental in turning what I will call a massive amount of data and modeling into a manageable and usable report that we think has been very helpful to the field. Giovanna Braganza is a senior research analyst in our Medicaid Institute at UHF. And Amy Lynn is a special assistant for program and policy, helping me work across all of the institutes and departments at UHF. So I'm going to turn it over to Giovanna. She's going to share her screen and get started with an overview of our report.
Thanks, Chad. So today we'll go through some of the key findings from the report. And what's unique about this report is that we combine data from 5 national surveys of youth to really get the most comprehensive picture of the scope of this crisis. We also took cuts of the data by region. So we looked at the United States as a whole, New York State, and also New York City. So we found that across all age groups, that adolescents, so specifically children ages 12 to 17, have experienced the highest year-over-year increases in behavioral health conditions and symptoms since 2010. And as Chad mentioned, this has been a crisis that has long since been increasing since before the pandemic. So in this top part of the figure here, more specifically, there was a 9% year-over-year increase in the rate of adolescents experiencing a major depressive episode. Over the past 5 years, there was a 7% year-over-year increase in the rate of adolescents experiencing clinically diagnosed depression and anxiety. Here you can see a snapshot of the most current number of adolescents experiencing behavioral health conditions. The numbers both nationally, which is represented in this blue color, and in New York State, which is represented in orange, they're both striking. In 2022, 4.3 million adolescents experienced disordered eating, 4.1 million experienced anxiety. And when you consider the impact of co-occurring conditions, A total of 6.7 million adolescents in the US experienced one or more behavioral health conditions. So that included anxiety, depression, ADHD, and behavior problems as well. And in New York State, an estimated 1 in 4 adolescents experienced a behavioral health condition in 2022. To put that number into context, in the same year, only 9% of adolescents had asthma and about 16% suffer from obesity. We also found that feelings of persistent sadness and hopelessness are consistently increasing among high schoolers, so those ages 14 to 18. And this was a trend that we saw across all geographies and pretty consistently has continued to increase. So year over year, over the past decade, nationwide, there was a 4% increase. 3% year over year increase in New York State and 4% in New York City. It's also essential to look at this crisis through an intersectional lens. We found that breaking down the number of high schoolers who seriously considered suicide and attempted suicide by race confirmed a disproportionate impact on Black high schoolers in the United States. So you can see in the top part of this figure here, Black high schoolers are represented in this dark blue line, and they had a 5% year-over-year increase in the rate of considering suicide. In the bottom part of the figure, you can see there was a 6% year-over-year increase in the rate of suicide attempts among Black adolescents. And in 2021, the rate of attempted suicide among Black high schoolers was higher than that of all other racial groups. In New York State, we found that Black and Hispanic high schoolers were nearly twice as likely to attempt suicide from 2019 to 2021 when compared to their white peers. We also looked at depressive symptoms and suicidality among high schoolers by sexual orientation and found that lesbian, gay, and bisexual high schoolers also had an increased likelihood of depressive symptoms when compared to their heterosexual peers. In 2021, in the United States, New York State, and in New York City, lesbian, gay, and bisexual students were around 2 times more likely to feel persistent sadness, 3 times more likely to seriously consider suicide, and 4 times more likely to actually attempt suicide. It's important to note that we could really only speak to the challenges experienced by those identifying as gay, lesbian, or bisexual just from limitations of available survey data, but we're thankful to be joined by Callen-Lorde to better speak to the LGBTQ perspective. And now I'll pass it over to Amy to talk about access to care and the ripple effects of this crisis.
Yeah, thanks, Giovanna. Now that we have kind of a clear picture of how many adolescents in the US, New York State, and New York City have a behavioral health condition who's disproportionately affected, we really wanted to look at whether or not those significant needs were being met and what level of access to care there was. And unfortunately, we saw that there is a lot of major gaps in access to care. Here on this graph, we're looking at adolescents who reported symptoms that were indicative of a major depressive episode. And this is a nationwide graph, and it basically has the orange bars representing those who had a major depressive episode and received care for it, and the white bars are those who had a major depressive episode but did not receive care for it. So if you look just at 2021, we're seeing that only about 39% of those nationwide who experienced a major depressive episode were able to access care. That means that over 60% of those adolescents were not able to get the mental health care that they really needed. And then we're also seeing from 2010 to 2021, you can see here the orange bars and the white bars are both increasing in size. This is because the rates of adolescents who experience major depressive episodes over this past decade have increased every single year. But it's remained pretty fairly consistent across those years that only a little bit under 40% of adolescents with major depressive episodes are receiving care. Next slide, please. So then when we look more specifically at New York State, we know that 340,000 adolescents experienced one or more behavioral health condition. That includes depression, anxiety, ADD, ADHD, and behavior problems. And of this 340,000, we do see slightly inflated rates in terms of access to care. So 58% were able to receive access to care in New York State versus about 40% nationwide. But it's also not necessarily like a one-to-one comparison, just because on the last graph, we were looking at major depressive episodes. On this graph, we're looking at a kind of slightly different set of behavioral health conditions. But either way, that's still 42% of New York adolescents who are not receiving the mental health care that they need. So it's really clear that access to care is a top priority. Next slide, please. So finally, I'm going to talk a little bit about the ripple effects that we identified in the report. As Chad had mentioned, this report is part of a series of reports that look not only at the sort of immediate need and care delivery, but also the more long-term impacts on the individual, family, and society. So in the short term, or technically more short term, we're seeing large impacts on education loss and family economics. So here, basically what we did was looking at scholarly articles that told us how a behavioral health condition may impact one adolescent in terms of how often they go to school. And then we sort of blew it up on a bigger scale by multiplying by the prevalence of behavioral health conditions nationwide. So we found that on average, one adolescent may miss 14 additional days of school due to having one or more behavioral health condition. In some, that leads to about 94 million days of school missed by adolescents, which can be up to 220,000 high school dropouts and over 200,000 additional college dropouts. And then we also looked a little bit at the impact on sort of the family level. We know that parents might have to take time off from work or skip work in order to take care of adolescents who have these behavioral health conditions. So we saw that this was up to $12,500 per family affected in lost wages. That's up to $11.5 billion nationally. Next slide, please. And sort of the last set of ripple effects that we looked at was even more long-term in terms of the effect on health and productivity. Again, we looked at these scholarly articles that really indicated that adolescents with behavioral health conditions can also later on develop things like alcohol use disorder, tobacco use and smoking, and obesity and high blood pressure. So in some, with all of these different health conditions, this can be up to $185 billion in lifetime medical costs. And there's also effects on the work and productivity of these individuals. So this can be around $3 trillion in lifetime lost productivity and wages. Next slide, please. So essentially all of this data that we've gone over today and in the report really shows that the issue of the adolescent behavioral health is truly a crisis in the nation and also in New York State and New York City. There's a lot of ripple effects that, can impact far into the future. And without access to care, it just means that more and more adolescents will continue to suffer. And we really do need to invest in targeted services to treat adolescents. That's why we're really excited about the conversation that we'll have next in this webinar to talk with some of the folks who are doing great work on the ground that is helping take care of our adolescents here in New York. I just wanted to quickly thank our partners at BCG for the analytic modeling and expertise that made this work possible, and also the broader team at UHF that engaged with BCG, worked on the report, and helped us get it into the hands of all of you interested readers. Thanks for taking the time to listen to our presentation on the findings of our UHF report. Please feel free to put any questions in the Q&A or to email Giovanna or me directly with any questions. Our emails are here on the screen. I'll pass it back to Chad to introduce our wonderful panelists.
Thank you so much, Amy and Giovanna. It is fantastic to work with such great young talent that really helps us take masses of information and make it understandable for the field. And in doing that and other work at UHF, we often have a focus on either specific subpopulations or specific care settings where we think there are great opportunities to enhance access and reduce health inequities. As we thought about those tactics in relation to our findings in the report and where adolescents could most efficiently and effectively access appropriate services, we immediately knew that we wanted to focus today on school-based care and the unique needs and services that are necessary for the LGBTQ plus community. While there are tons of great organizations working in this space across the city and the state, we're really fortunate today to be joined by two of the biggest and most well-known providers. Dr. Erica David is Director of Mental Health Services at the Montefiore School Health Program. And Aruna Krishnakumar is the Managing Director of Adolescent and Mobile Health at Callen-Lorde Community Health Center. And as I get them up on the screen with me, I'm going to ask each of them to take a few minutes and talk about their organizations and their roles and some of the current realities that they're facing on the ground, addressing what we've seen are the significant behavioral health needs of adolescents. We'll then have a little bit of a back and forth conversation around a few questions, and we'll leave some time at the end for questions from the participants. And just a reminder, folks on the webinar, you can submit questions at any time using the Q&A feature at the bottom of your Zoom window. So with that, I will turn it over to Dr. David to kick us off.
Thank you. Hello, everyone. As Chad has mentioned, I'm Dr. Erica David. I'm a licensed psychologist. I'm also the Director of Mental Health in the Montefiore School-Based Health Program. I'm happy to share information about our program and be here today. Currently, we have 33 locations that are throughout the Bronx, and now we have expanded into Westchester County and have one location in Yonkers. We serve a diverse population within the public schools of New York City and have a few charter schools that are amongst our sites. The students that are enrolled in the buildings that we are located are the students that are able to access our services. There is no out-of-pocket cost for the families. They'll never receive a bill from us, so we're able to provide comprehensive care. We aim to reduce absences, improve their academic performance, and promote health and well-being among all the students. As of April 2024, the population that we're able to serve is about 38,000 students that can access our care within New York, which is really amazing. Total enrolled as of April 2024 was about 24,000, and the percentage of enrolled students that have had visits about 62%. So although we have 33 locations and a lot of ability to access so many students, one of the things we're really working on is to make sure that all those students are accessing the care. The services that are available to them include medical, mental health, dental, vision. We work on health education and nutrition counseling. So we have a team of professionals in all of those locations working together to provide integrated care. The mental health services that we have, we'll have one provider when we are fully staffed at each of those locations. Their services are provided by licensed psychologists, social workers that are licensed, and as well as psychiatrists. We also have family support workers and social work assistants that help support those services and work with the students and their families. Our locations are Article 28 and Article 31, so there's different resources that are available. Our Article 31s are the ones that are able to receive psychiatric services with our psychiatrists, so they are able to be prescribed medications to help manage any of their mental health conditions. Overall, our providers are engaging the students while they are in school. We're there every day that the school is open. We're providing individual therapy, short-term and long-term. We are providing crisis intervention when it's needed. Group counseling is happening when it's available at different locations. We are working closely with teachers to provide consultation and support, engaging families and guardians and caregivers that are able to participate. The one silver lining I think of COVID was that we were able to include telehealth into our services, and we are continuing to do that. Even though we are back in the schools and providing direct care, telehealth is something that we are utilizing to get families and adults that are engaged with their young people so that we can have them participate if they're not able to be in the school. And that has been really a nice added feature. A lot of the adolescent challenges that we're seeing were highlighted earlier. We are seeing a lot of exposure to trauma and a lot of increased family mental health difficulties that the students are, exposed to as well. The psychopathology that we're seeing has just really increased over the years. The severity of the symptoms, the frequency in which, different things are occurring has really increased. Students and adolescents are dealing with much more grief and bereavement. There's more increased severe depression symptoms and anxiety that we're working with them to help manage. Increased social stressors, low self-esteem is very common for a lot of the young people coming in talking about that. Immigration-related stressors has been significantly higher over the last couple of years. We are seeing increased use of substances and addictive-like behaviors with technology. Poor sleep hygiene, which impacts attendance. A lot of our classes start 7:45, 8 a.m., 8:30. Students are not in the building. We're really trying to help them get there at that time. And some of the problems that we're seeing also are related to executive functioning. So organization, focusing, they may not necessarily meet the criteria for ADHD, but they're struggling with a lot of the symptoms of ADHD or just basic development of skills that haven't happened over the course of high school or middle school for them. Some of the barriers that our program has is staffing. Overall, we are, as I mentioned before, in person every day when the students are there. That's where we want to provide the services. And with hybrid availability for many people in the mental health field, people may not want to come in and provide direct care every day in the schools. So we are having some staffing challenges. I think that's across the system, but that is something that we are working very closely to, try to engage more people to come in and provide those services. As I said earlier, with some of the numbers that I shared that about the population and who's accessing the care, enrollment and knowledge of service is something that is a barrier at times too. So we want the kids to know where we are, that they're able to come and get us. There's sometimes misperception as to that we will take away somebody that they're connected to in the community that provides their medical care, and that's not true. So 62% of the overall population is using us. We want to increase those numbers and allow more students to access the care. Staffing obviously is a big part of that. We have a lot of staff that community health organizers that go in and get the word out, and we need more of that as well. Our reimbursements is also a barrier for us in our program. 10% of the patients that we see do not have any insurance. So as I mentioned before, we will bill for insurance, but not the services are at no cost, so we will never send a bill to them. So if they have insurance, we will bill it. If not, we don't send them a bill. So with that, if not all of the insurances, we have reimbursement challenges, and the cause could be billing issues or errors on the system, but that's something that we deal with on a regular basis. Our program is really trying to expand our services and how we provide students care. We really have been working hard on decreasing the stigma and increasing our visibility so people know that we're there to help them. A lot of our staff are getting trained more and more in evidence-based services and trauma-informed treatments such as EMDR or DBT or MI. Those are really great interventions that we're utilizing in the schools. We're trying to engage guardians, as I mentioned, with telehealth. We're also trying to use telehealth for those students that are not in the building. Why did you miss school? Can we get you in halfway through the day? Are we having anxiety about getting into the classroom? Let's work on that. So telehealth has been a way that we can access students that just are not in the building. And then we are really working this year to initiate more ways to engage males. There's less males participating in mental health services, and we're really trying to work on improving access to care for the males within the schools.
Sorry, I was talking on mute. A lot of fodder in there for further conversation. but want to give Aruna a chance to jump in here and talk a little bit, broadly about your program, and then we'll come back to what I'm guessing are going to be some, common opportunities, barriers, and challenges in some Q&A.
Thanks, Chad, and thanks, Erica. So my name is Aruna Krishnakumar. I use she, her pronouns, and I'm the Managing Director of Adolescent and Mobile Health at Callen-Lorde. So Callen-Lorde is a community health center. We're an FQHC, and we have 3 brick and mortars, one in the South Bronx, one in Chelsea, and then we have our newest site that we opened in 2020 in downtown Brooklyn. I'm going to talk a little bit about our adolescent program, which is called the HOT program, which stands for Health Outreach to Teens. HOT is a welcoming, non-judgmental program that's designed specifically to meet the needs of LGBTQ young people ages 13 to 24. And similar to Erica's model, we see young people regardless of ability to pay. So we see folks who have insurance, and if they don't have insurance, then we still see them at no cost. I think for us, the breakdown is a little bit different. We see about 30% of folks are on private insurance, guardian insurance, about 40% have Medicaid, and then another 30 are uninsured. Within that private insurance, though, I think one of the biggest barriers that we can definitely talk more about is safety concerns. And so even if some of our young people have insurance through their parents or through their guardians, if there are safety reasons that they cannot use their insurance because of the services that they're accessing with us, we then cover those costs. So just a little bit more about our program. We offer primary care, transgender care, including hormone therapy and navigation for surgeries, HIV care, sexual health, including STI treatment and screenings, HIV treatment and testing, and also PEP and PrEP care. We also have women's health services, including GYN care, and then we have a lot of supportive services, including care coordination, therapy and psychiatric care. We have on-site pharmacies at all 3 of our locations, and we also have insurance enrollers. One of the other things that we really provide is our mobile health program, which I will talk a little bit more about as one of the things we're excited about, and a real opportunity in terms of health and mental health services for young people. So just to give a sense of some of our numbers, we at Callen-Lorde see about 18,000 patients a year, and the HOT program sees around 14 to 1,500 patients a year. Of them, only about 10% of our patients are minors. 61% identify as non-white or POC. 86% of our patients identify as transgender or gender non-binary. 8% are living with HIV. And, in the 10 years that I've been here, that number has steadily decreased. And 1 in 4 HOT patients are connected to one of our behavioral health providers. So similar to Erica, we use an integrated care model where we have medical providers, behavioral health providers, case management, nursing, all working together to really provide the best care that we can for our young people. Some of the things that we do that are unique are really around providing an affirming space for LGBTQ youth. And so in our safety assessments are really important in our registration, in our behavioral health assessments, and then also in our medical visits. Sometimes we involve parents, sometimes we don't. With minors, we do require adult consent, guardian consent for primary care, but of course not for sexual health and not for our short-term mental health services. Some of the mental health trends that we're seeing are very similar to what Erica also mentioned. We're seeing a lot of housing instability, whether it's family instability in terms of housing or it's individual young people. Young people who are LGBTQ identified are 20 to 24 more likely percentage more likely to be housing unstable or face family rejection, of course. We're seeing a lot more issues around immigration and newly arrived immigrants. We're also seeing a lot of folks who are coming from out of state, who are coming here specifically to access either HIV care or transgender care because of state bans on those kinds of care. Of course, we're also seeing the impacts of that on their mental health. In a recent Trevor Project survey, we saw that 90% of LGBTQ youth reported their well-being being negatively impacted by the current anti-LGBTQ laws. I think Giovanna did a great job of showing sort of larger trends around mental health issues for LGBTQ youth. But just to continue with that, 39% of LGBTQ young people have seriously considered attempting suicide in the past year. And of that, that includes 46% of transgender and non-binary young people. Some of the barriers that we face, one is just in terms of the care that we're able to provide to our young people. We're an Article 28 clinic, and so, it's a short-term model, and many of the young people that we're seeing are coming in with substance use issues or needs for higher levels of care. There's such an issue around capacity. While we're very lucky in New York that there are lots of places to refer, for long-term behavioral health services, there is just wait lists everywhere. And so finding places that are affirming to LGBTQ youth and also are able to take people regardless of insurance is a real challenge. And so we're able to provide that short-term care, but the long-term is really what, we're lacking. One of the other interesting things that's happened through the pandemic is we used to have a lot more support groups, and that's been a challenge to get young people to come back into the space. I think young people have done a great job of adjusting to a more electronic, world, and like Erica said, adjusting to telemedicine. I think we've been very successful in pivoting to telehealth, but then also being able to have on-site clinical services. But our support groups has definitely been something that's lacking, and it's hard to get young people back in the space when they're really used to looking at screens. In terms of some of our more operational barriers, I think very similarly, the workforce, people are more used to being able to work from home. And so getting people who are interested in being on site and having a hybrid has been a challenge. We definitely face a lot of issues around regulatory issues. Our licensure is definitely an issue. Like I mentioned, having only Article 28 be for short-term mental health services rather than being able to provide comprehensive substance use treatment and also long-term therapy that, say, an Article 31 or 32 could do. So we really are advocating for an integrated license. In terms of things that we're excited about, I think we have really seen the benefits of being able to incorporate telehealth into our model. For a lot of our young people who are transgender identified, there are often a lot of safety concerns of even commuting from wherever they're staying to the clinic. And so this offers an opportunity for folks who aren't able to come on site to be able to access mental health services anywhere they are. I think the other thing, as I mentioned, is mobile health. And, we have a mobile medical unit that is a fully equipped vehicle that has, an exam room, has phlebotomy, has a small consult room for short-term mental health assessments. And I think that has been a real success in our program, to be able to go out and meet young people literally where they're at, geographically, going to parks, piers, going to shelters, drop-in centers, but also just all over the city where we know that young people are hanging out and may not be coming in for care. On the mobile medical unit, we're able to do almost everything that we're able to do in clinic. So urgent medical care, sexual health services, STI and HIV treatment and testing, physicals for schools, vaccines has been a huge one. Last summer, we did a lot of our Mpox vaccines through our mobile medical unit, and just providing supportive counseling on our mobile medical unit has been a huge thing. So I think there's a lot of potential there for us to grow in terms of mobile health and then also telehealth. So it's just really seeing how we can provide care outside of our brick and mortars and what would traditionally, a mental health model. And so with that, I'm going to end and open it up to Chad.
Great. Well, thank you, Aruna, and I'll bring Erica back up front and put me in with you all. Thank you so much for those overviews. Obviously, you both do an amazing amount of work to meet the needs of the populations you're serving. A specific subpopulation that both of you mentioned is really the influx of new arrivals. And I think about that in the context of our report. Those people surely aren't showing up in the data yet, but many of those adolescents, new arrivals, are coming with a significant amount of trauma that they've been through either in their home country and or on the journey that has gotten them to New York City. So how do you deal with that influx of a different type of subpopulation that needs, trauma-informed care? You have to think about cultural humility, language access and different languages showing up than you've historically had to do. So what's your response been to those, new arrival populations?
Yeah, I think we're seeing a lot of newly arrived immigrants in our clinic, and then also through our mobile health program. A lot are coming onto the van, and we're seeing things that we haven't seen traditionally. A lot more respiratory issues. As Erica said, a lot of family trauma and just the trauma of migration. And so, I think while we use a language line, it doesn't always equate to the same kind of care that, speaking the same language as a patient does. And so there are definitely challenges. I think our providers do the best that they can in terms of using a language line. We've also offered trainings to our language line on LGBTQ competence. So, they're able to be culturally competent and have cultural humility around even translating, especially in languages that might be very gendered. And so we pivot as much as possible. I think the real challenge is just finding young people housing, because there's such a crisis around finding any housing options for the young people that we're seeing. And that's something that we don't necessarily take care of, but we're hearing that, every shelter is full. And so just the impact of that on someone's well-being is tremendous.
Erica, anything to add?
Yeah, I would just echo that, and I would just say that our providers are definitely using the language line, which we are fortunate to access hundreds of different languages. So that really helps all providers to engage families. We're also just doing a lot of education and consultation amongst each other and reaching out and networking to obtain information about community-based programs that maybe we're not aware of, and can continue to build our resources to help our families connect if within Montefiore we're not able to provide them. So that's definitely something we're all hands on deck trying to do.
Great. You both mentioned workforce, especially in the context of people preferring hybrid or work from home situations. What do you think we as a field or policy wise, or what are some solutions to making sure that you guys have the workforce you need that's willing to come in and do the work that's so important to meet these adolescents' needs? Or is that a question you want me to try and answer?
I think that the report shows, how much we need people to focus their attention on this. So we need people to want to pursue higher education and to really understand what the needs are and to get out there. And, I think that some of our jobs are not always the most rewarded financially, right? And so maybe that's the part too, that some of our professions need to get the recognition that they deserve to help people want to join such an important field.
Yeah, and along those lines, I think if our, social workers and therapists and psychiatrists didn't have to deal with all of the stuff around credentialing and the complications around reimbursement rates and billing, I think a lot of that stuff makes the job much more challenging, right? And many of them are so dedicated to our mission, but it's those things that are especially challenging, right? And so if they're able to see young people for however long they want, to not have, certain stipulations around, the utilization reports and like budgets, I think that would really help. And so I think, that's a big piece of it. But I agree with Erica. I think a lot of it is around just being compensated for the really difficult work that they do.
Indeed. Aruna, you'd mentioned kind of the adolescents, comfort with being on screens. And obviously there's been a lot of talk, the Surgeon General, the governor, the commissioner of health, the mayor, about kind of the impact of social media on adolescent health. And some of that conversation has lacked some nuance. Can you talk a little bit about how you see the impact of social media on your populations, and how does the field need to think about this from a little bit broader perspective?
Sure, I think there's a lot of challenges, right, with social media and young people and screen time, as Erica said, just attention issues. And then also just in terms of social media specifically, seeing a lot of specific kinds of body image issues arise through social media. At the same time, I think it's really important for us not to completely negate the importance of social media and just the ability for young people who may be very isolated to be able to connect with one another. I think especially for LGBTQ youth, especially during the pandemic when they were really isolated, the internet did provide a space for them to connect and ask questions around their sexual health, right? Their mental health, talk to peers, but also talk to professionals. And so I think that there's a huge, positive there and a potential there. I think the other thing is, in the last, 10 years, there's been a lot more visibility in media of LGBTQ celebrities and, important figures. And I think that has had a huge impact on young people being able to see what their futures could be, to see that, they can be lawyers, they can be doctors, they can be actors, they can be models. And so I think there's a huge potential there, right? In terms of why it can be really important to see people who look like you, who identify like you, and get that information and not have all that information only be channeled through, what a parent or a guardian is allowing you to access. At the same time, I completely recognize that there's a lot of dangers in that as well.
Erica, anything to add there?
Right. I agree that social media has allowed mental health to really get some of the attention that it has needed. More and more people are speaking up and spreading the word about normalizing it's okay to talk to somebody, decreasing stigma, increasing awareness. So there's so many positives of that, allowing young people to express themselves and, be able to build that confidence and connect to community and others. For what we're seeing in the schools, I think a lot of it is teaching just moderation, right? Teaching someone when to turn off, how often they should be on it, or what's most effective for them. It really impacts sleep, right? So we just want people to learn to utilize social media and electronics in a reasonable, helpful, healthy manner, and that it's not going anywhere. It's just how do we live with it and how do we do it responsibly. There's a lot of bullying that goes on, and I think there isn't a part of addictive behavior that we see that the kids just can't turn it off. It impacts their focus, and engages some of the harmful behaviors that we're trying to change. So moderation and a little bit of harm reduction really is how I think we try to intervene in our setting.
Great segue. Thank you, Erica. Thinking about harm reduction and thinking about getting upstream of some of these issues, and are there things that we can be thinking about, for protective factors, that would help reduce the prevalence and the severity of what you're seeing by the time people are getting to you. Thoughts on, working with others or bringing some of that, prevention into your own work. And while you guys talk, I'm going to bring Amy and Giovanna in and ask that people get their Q&A in because we'll go to audience Q&A after this. So prevention.
Right. So for us, we definitely are doing prevention at the start. I think just enrolling the students and having them know about our services is a first line of defense. And our medical providers are doing screenings ongoing with our students to intervene early. And that helps us identify those students that may have some things that are leading towards a path that we want to intervene on. We are definitely trying to share resources with the schools and the teachers and the guardians for them to be more educated and be more aware of like when a problem may exist, what it looks like, how do we help develop skills that would deter from having longer term problems. So we're definitely doing that. We're trying to get in to do more, professional development stuff for the teachers and giving them workshops and push-ins to the health classes to support the students for them to learn as early as elementary school, going into have them be more mindful of mental health and wellness. So because we are where they are 8 hours a day, we try to really access and do the preventative work as well as intervene. The screenings are really important. And then of course, we're trying to connect kids to community programs. So summers, we're trying to get them connected to the public libraries and all the parks and recreations. And, New York City Police Department does youth programming, so while we're intervening, we're also trying to highlight all the great resources in the community to help build skills that will help people be successful and do well. And those are some of our preventative measures.
Yeah, similarly, we do a lot of community engagement, a lot of tabling at different community fairs, schools, and then we also do a lot of presentations and workshops, both for professionals and for young people. So that's a big component of, just talking about mental health and LGBTQ youth, and also just providing some LGBTQ competency trainings. A lot of what we do, especially on the mobile health program, is really around prevention and just health education. A lot of young people will come on and just ask questions, but not necessarily access services. And it sometimes takes a couple of times, right, until they're actually ready to access some of our services. I think a big component was our support groups. And I think because that has been a challenge to get young people back in the space, a lot of that was around prevention and also peer support, which I think is so important for, a really comprehensive prevention model. And so we're working more on that, engaging community health workers as well, to really do some of that work.
Amy, Giovanna, anything to add on that front from the UHF perspective?
Yeah, I think we would kind of just echo a lot of what Erica said in her response. I think that there's just a lot of sort of preventative work in terms of all different members of the community playing a role in really making sure that we build up resilience in young children, that we work on more earlier childhood mental health and social emotional development, promote connectedness between children. So yeah, even things like summer programs, athletics, the arts, I think the whole community has a role to play in terms of being able to work on prevention and identifying early on if there may be something going on in a child's life.
Great. Well, I see some questions from the audience, and we'll jump in on a couple of those. I think this one goes back to something Aruna said about kind of those longer term care needs and the wait list for those. What kind of services are you talking about when you talk about those longer term care needs, and kind of what type of program is that you're trying to refer out to, that you're struggling to get people connected to?
Yeah, I think we struggle with one of the biggest referrals that we have is for DBT programs that are really comprehensive and provide both psychiatric and, counseling therapy services and groups. And so that has been a challenge. Definitely substance use treatment has been really challenging for us to find, culturally competent programs that also are not completely inundated or flooded with referrals. And then even even inpatient programs have been a struggle. I think one of the strengths that we have found is some of the respite programs for a lot of our young people, but those are, time limited and they're very limited in the city, but they've been really, really helpful for young people, especially those who don't feel safe at home and are struggling with a mental health issue. I think in addition to that, just referring to culturally competent therapists who are able to see someone, in their private practice, but, may have a sliding scale or may, take insurance, fewer and fewer private practitioners take insurance, right? Because of the regulations and just the administrative burden that's on them. And so I think that has also been a challenge, even for families who are willing to, find a therapist, do family therapy and individual for their young people. That's been a challenge. So I think it's programs and just long-term therapy in general.
Great, thank you. I think a question this probably relates to Erica, how do you think about consent and confidentiality in the context of, you guys having medical and mental health information kind of in a school setting and making sure that that's not ending up, in school records, in the school safety officer, realm or getting into the justice realm in any way, shape, or form?
That's a great question, and I apologize I didn't talk about that. It is important. So because we are Montefiore, we are a medical center, and we have medical charts that we're keeping as if someone were to go see a practitioner at a community health center. We are just located in the schools. So once the students enter the health center, they're part of Montefiore. And so we abide by all the Montefiore regulations that a health center has and protect the privacy of the patients. And so in order for us to engage with the school and share more information, we do have a release signed by the guardian to allow us to provide, and it's only verbal consent. We're not providing any of the written documents or anything for the medical chart. If a family wants to have that, they have to go through the medical records as if they would at any doctor's office. So we are able to keep that very private and confidential for them. The schools do help us with getting the students in for appointments, but they never know who the child is going to see. So because we have multiple providers, they just know that the student has an appointment. So, Erica has an appointment at 10 o'clock. They don't know if it's with the dentist, the optometrist, the mental health provider. We're not sharing why they're in the clinic or who they're seeing. So, we are very, very strong in protecting our patients' privacy. And if we don't have that consent, we're not sharing information. There are safety, things. If we have to transport someone to the hospital, safety is something that we have to, abide by that. And it is a limit of confidentiality that we are able to breach, but within the context that the school needs to know we are transporting this patient. They don't need to know all the backstory as to what's going on.
Actually, I think channels nicely into the next question, which is thinking about, building on something you said, Aruna, about it may take multiple times to get an adolescent to really want services. But when you as a provider, identify somebody that probably needs help and support, but for whatever reason doesn't want to pursue it immediately, kind of what is your responsibility as a provider around those things? And is it depends on the level of risk and the safety concerns?
I mean, I think this goes back to what Erica was saying about harm reduction, right? And, I think we have an integrated care model for a reason. And so often, the case managers are the ones who connect best with the patient or even our front desk staff. And they're all trained in trauma-informed care. And so while they're not therapists, right, they are able to at least engage the young person in reminding them of appointments coming up or making sure that, at least they're taking care of their medical needs, even if they're not yet in, therapy with us. And so I think it's really using, our case conferences to talk about those young people, figure out different strategies to engage them. I think also we do so much community outreach. And so sometimes we will see our young people, out in the field. And so trying to engage them there and trying to, you know, make an appointment to get them in. Sometimes, yeah, it takes a couple of times. But, you know, we've also found, I think the strength of mobile health is that young people often like to access services all together as a group. And so we're able to do that and accommodate that. And so, you know, if 3 or 4 of them are coming on, you know, our mobile medical unit, then we see all of them, you know, separately, of course, but at least they're all there together. And, you know, it feels like something that's more empowering and that they have some autonomy over, you know, their choices.
Great. Well, we are actually approaching the hour. I cannot believe how fast this went, but I want to take this opportunity to thank all of our participants today, Giovanna, Amy, Dr. David, Aruna, for your time and sharing your expertise. I think, you know, we read a lot about this stuff every day, but I think we at UHF really cherish these opportunities to bring the data together with the people that are really doing the work on the ground so that we can all inform, you know, what we need to do to make this better for New Yorkers moving forward. Finally, I'd like to thank everybody that joined us today. We had a great registration list and a huge number of participants today. You know, I think that's evidence that this is a really important issue. It's going to take a village to make improvement on this really important issue. And all of you that were on today, by your dedication of time and thinking about these issues, you're going to be part of the collaboration that's necessary to enhance adolescent behavioral health care as part of, you know, our mission at UHF, a more effective and equitable healthcare system for all New Yorkers. So thank you, everybody. And Aruna, Erica, thank you especially for your time that you put into really sharing the great work that you're doing here in the city.
Thank you.
Yeah, thank you. Thank you for having us.
All right. Thanks, everybody. The great work that you're doing here in the city.
Thank you.
Yeah, thank you. Thank you for having us.
All right. Thanks, everybody.